If Dr. Gales or Dr. Stoddard, whoever would like to lead this off, please do so.
Gales is under more time pressure than I am, so if he wants me to go first, either way, I'm good.
Well, we're all under. We got to get out of here. We have to stop this at
No,
11:50.
I'll start because I think mine will be shorter. I know you have a lot of questions for Dr. Gales, and you may have many for me as well, but I'll start done quickly. Thank you, Council President Katz. Thank you, members of the County Council, for inviting us back to talk to you again. I want to go over a few updates on our COVID-19 response and hit on, I think I have about 7 areas I can talk about very quickly that I want to touch on. We're working on a lot of things. It's very busy right now. The governor's announcement, I'm sure Dr. Yales will talk about this a lot more, has created a lot of questions and a lot of things that we have to respond to, and so we're working to do those very quickly. But I want to touch on some other areas and let Dr. Gales sort of talk more about the public health side. So for PPE, we continue to receive good amounts of PPE in, and we continue to increase the amount of PPE that we're distributing out. There are several areas that we are focused on right now, not to say that other areas are not getting PPE because they are, but we've increased the PPE allocations that we're sending out to our DDA providers, group homes, nursing homes, long-term care facilities, and child care providers, as well as cleaning supplies to the child care providers. We're doing a distribution this week to the more than 400 essential child care providers, and what we found is actually there are a number of child care providers who were showing up that were not on our list that will have additional needs, and we're going to have to expand that effort considerably to make sure that we're accommodating those needs as well. For 311, we receive a considerable amount of interest and questions about COVID-19. For context, yesterday we received 362 calls on COVID-19 to the 311 call center. That was about 17% of the total call volume. The number one topic has been and continues to be the Emergency Assistance Relief Payment Program, the EARP program. There were 93 calls on that issue alone yesterday, and roughly 75% of those were to the Spanish language queue, and that has been relatively consistent throughout since the launch of the EARP program. For the Food Security Task Force, there's been some great work that's been done countywide, led by our nonprofits in most cases. We're helping to coordinate on the back end, but obviously our role is much more to provide them resources and logistics support to do the critical mission that they do on a day-to-day basis, and that's great work. I know several of you are familiar with the efforts. I know, Councilmember Jawanda has been out at the grab-and-go events and helped organize those as well. They're a perfect example of the way the community has stepped up to help out all of our residents. We had an event with Yada Yehuda yesterday where we did, I think it's Tuesday, 1,900 kosher meal distribution, and that's a great effort and will be repeated again moving forward. We had the Food Access Grant. The applications were, turned in last Friday. There were 105 applications. 38 organizations received awards ranging from $7,000 to $60,000. The goal that Food Access was to improve access to our hard-to-reach communities, non-English speaking and others. The 67 organizations that did not receive awards, we're going to actually continue to work with them. The Food Council is actually going to try and connect them to other funding opportunities that may exist, as well as just integrate them more into the systems that do exist and can allow them to continue to work forward. We're also looking at a platform that will do some more coordination. One thing that we've heard loud and clear is that people aren't necessarily always aware of all the opportunities that may be available to them. Obviously, a lot of these are nonprofit or community organized. And so the goal is to obviously have some sort of centralized coordination of all those incredible efforts so that when a resident is seeking food access services, they can be, they can go to one place and be able to, be directed to the resource that makes the most sense for them, that's appropriate by language, culturally appropriate foods, and geography. And so we're working on a system that there's actually a system in place in DC that does this. We're looking to actually expand that to Montgomery County and allow us to operate in a manner that's in partnership with the district, because obviously we have, we see borders differently than our residents do in some cases, and so they travel back and forth between us and the district, and we want to make sure that we are coordinating with those that have a platform in place. We consider to see a considerable number of donations, and obviously we appreciate all the donations that are coming in, both financial as well as personal protective equipment and food. Some large organizations like Meduni and Project Hope have made substantial donations of PPE this week and medical equipment. and we absolutely appreciate the big donations, as well as the MoCo mask makers and others making, repetitive smaller donations, because obviously everything that we're receiving, we're turning around and it's going to a direct benefit for those who need it. We continue to work on expanding our hoteling options for those who need quarantine and isolation. We have 2 additional hotels that we're fairly close to being able to announce. I would expect that we'll be able to provide an update on that likely tomorrow, as we work on some of the final details on being able to expand those options. In addition to identifying the locations, we want to make sure that we have vehicles in place for those residents to be able to be identified and actually access that service. And so we'll be able to talk more about that as well tomorrow. We're fairly close, and just obviously the logistics details of that are considerable. As you are all likely, or you should all be aware, I think with maybe one exception, we have some projections for how we'll utilize the coronavirus relief fund. Those do include integration of how we have a projection of things that we're likely to need over the next 7+ months. We're also looking to increase the pool of resources that are available for that purpose by going to FEMA for reimbursement for things that we believe are eligible. We are beginning that process this week, and so we're hoping to have our initial request to FEMA, and we'll do this on a rolling basis. Obviously, the FEMA activity is an exercise in documentation, so it can be extremely time-consuming to pool the data, and so we're trying to be strategic about identifying those things that we have the most concerns or questions about their eligibility to address first, so they can give us some certainty about how we can plan to move forward with the remainder of the coronavirus relief fund. I know our municipalities have had a lot of questions. We're actually going to be briefing the municipal leaders at 3 p.m. today. We have a quick explainer on how the process will work in terms of first getting them to apply for FEMA reimbursement, because obviously we want them to help us increase the pool of resources we have available to us. And then from there, we will utilize a portion of the coronavirus relief funds, we believe, to help them deal with some of the costs that they've absorbed that are eligible by the federal guidance. And so more to come on that, but certainly we're thinking about them, and we know that they've had significant concerns about the steps that they've had to undertake and the costs that they've had to bear as a result. And the final thing I'll talk about, and this is only very briefly because I think we're going to make some broader guidance on this, is we are working on a recovery framework. We recognize that, and I want to make it very clear, the notion of reopening and recovery are not necessarily synonymous, meaning that the reopening is a portion of recovery, but recovery is so much more than just reopening. There are existing issues within our economic system, as well as our public health inequities and other things. So we want to make sure that we're appreciating, as part of our recovery effort, whether it's around health literacy, whether it's around the issue of evictions once the moratorium on evictions is ultimately lifted, whether it's on issues related to the digital divide in our economy that may exist after this coronavirus has abated to a degree. We are not there yet, and you're going to hear that very clearly from Dr. Gales, but there's a lot of things that we have to have in place in order to be ready to go when we are there. And so those are the things that we're working on. We'll have more to add to that, and I will stop there.
Thank you very much. I'm going to go to Dr. Gales before we go to questions. Dr. Gales, please.
Good morning, everyone. It's going to be a fun day and a busy day today. Lots to get done. Always a pleasure to be with you all. I will go through this really quickly, or as quickly as I can. I won't leave out any details. But I'd like to walk through, and I think this will address anticipating a number of your potential questions, is walk through first the criteria that we would look at in terms of reopening. Now, we're obviously forced our hands a little bit based upon the governor's announcement yesterday. Let me say very clearly, from my perspective as the health officer of the county, is that we are not at the point where we are ready to reopen. And I respect the governor's decision and respect the data that he shared. We are not in a place to be able to move forward with that here in the county based upon the surveillance and epidemiologic data that we have in place. I'd like to walk through those measures and things that we're looking at. We'll give more insights throughout the course of the day. But I want to, as always, make sure that we have your thoughts and input on this. And so there's a host of categories that we're looking at that include the measures that the governor talked about, that the state has looked at in terms of measures to move forward. And so I'll go through each individual category as well as give some updates in terms of the things that we're doing in those areas. Let me also be very clear, is we don't look at this as the time to relax restrictions. Actually, it's a time to be more aggressive and to do some reflection in terms of what we're doing internally. So the first category is looking at the number of COVID-19 cases. As we've talked about before in multiple conversations, is that we can't look at the number of cases strictly in a vacuum. And particularly as we ramp up and scale up testing capacity, which I'll talk about in another measure, we have to think about the measures in terms of that. So we're looking to see a sustained rolling average and a sustained decrease in over 14 days and the number of new cases in the setting of increased testing. And so we, over the last week, for example, we actually did see a decrease in, at the beginning of the week in terms of May 7th, a decrease in the number of daily cases. However, that number increased on May 8th, 275 cases on that day, which was actually one of the highest numbers that we had experienced throughout. And then a slight uptick on May 12th as well. And it's interesting to report that the state numbers, just a few days ago, there was a report of over 1,800 cases. And this morning, actually, the report from yesterday today was that there were 1,000 new cases, which is actually up from 700 the previous day and up from 688 the day before. And so that's one number. But again, we don't look at the number of cases in a vacuum because we know that as we increase testing, that number will increase. And part of our job is to continue to tease out if that is a factor of strictly testing more people, which we don't think it's the case, or just making sure that we're identifying more cases out there and being aggressive if there is any evidence of any type of specific clustered outbreak. The second category of measures to look at are outcome-related indicators. So included in that category, and this actually also influences the third set of measures, which I'll talk about, which is hospital surge capacity, is sustained decrease in COVID-19 related hospitalization rate. We've talked about this before in terms of the rate is a good measure as opposed to just looking at the point in time measure. The state hospitalization rate and our hospitalization rate is consistent with the state, is approximately 19%. We would want to see a decrease in that number because if we see a decrease in the hospitalization rate, that also allows us to have more bed space, both from an acute bed perspective as well as an ICU bed perspective, in the event we see an uptick in cases or a surge at some other point in time in the near future. We'd also look for a sustained decrease in COVID-related ICU rates, a sustained decrease in COVID-19 related fatalities, with the goal of actually seeing single-digit fatalities a day at a minimum. Right now, we're seeing, anywhere from 9 to 12 on a daily basis. Certainly, we want to see that number decrease to a much smaller daily total. Certainly get to zero. A sustained decrease in COVID-19 like and influenza-like illnesses presenting in the emergency room and other healthcare settings, because again, we recognize that not everyone who gets COVID-19 is going to be hospitalized, and hospitalization rates aren't the only measure of the impact of the disease. Now that spills over into our third category, hospital surge capacity. We want to make sure that we have the ability to respond to an uptick in cases and have the capacity to meet that. So when we're talking about plateau levels, I know that was a term that was used a lot yesterday, is we don't want to just see a plateau at a high capacity. So for example, the last 2 weeks, we've had some instances where we have had a high percentage of we've not hit capacity for acute beds, but we have hit capacity on a number of days for ICU bed coverage. For example, just yesterday, 4 of the 6 hospitals were actually at capacity for ICU beds. Now today, we're happy to say that there's been a decrease and only 1 of the hospitals is at capacity or at high levels of usage compared to the others. But certainly we would want to see a steady decrease in the utilization of ICU beds as well as acute beds because let's say something happens again and we see cases uptick, we want to make sure that we have the capacity to meet that. Now, we do in our current setting, as well as we've created provisions to increase space, like for example, through some of the provisions at Kaiser, repurposing their acute observation unit, as well as repurposing space at the Washington Adventist Tacoma Park campus. And we also, again, want to see a sustained decrease in the percentage of emergency and critical care equipment, for example, ventilators being used by our hospitals. The next category is testing. I know we've talked a lot about testing capacity recently, and one of the measures, we've looked at a number of different places. So one question I want to answer, and this gets to a question that was sent in by Councilmember Reimer, is that I'm working to get a specific number of how many tests are done on a daily basis. That is tricky because there are, the private labs get the information. So what we do have a measure of each day is how many tests come back positive, as well as how many negative results are in the system. Now, our county testing apparatus that we use through our alternative test sites is producing approximately 750 a week. We had a goal of 1,000, and I know you talked about a goal of 2,000. I actually think the goal needs to be higher, and we need to work to get to a higher percentage, and that is having the capacity to test 5% of our population on a weekly basis. That is approximately 55,000, having the ability to be able to test 55,000 individuals. Right now, based upon May 11th, the most recent data from the state, we have tested over nearly 30,000 individuals, which represents about 2.8% of our population. So we have a ways to go. Now, the way to get there is, I was hopefully we'll be able to announce this, and I know I keep saying shortly, their contract's getting signed, but increasing access to testing opportunities through some high throughput testing, such as self-collection mechanisms and measures. Within that, we've talked about before in numerous situations where we would prioritize our first-line responders, also work with our nursing home facilities and our assisted living facilities to get those residents and staff members tested, as well as we move forward, those first-line responders and increasing that definition to also mean essential employees, our healthcare workers, our folks who've had to come out and work over the last 2 months and have not been able to stay at home and telework. The goal is, again, with increased testing, and again, there's other strategies too, such as, again, continuing to work with our healthcare partners, creating spaces for folks to be able to use alternative spaces for testing. We're not calling it the hotline. Our testing helpline that we've talked about did go live yesterday. There was a soft launch, and we did get some folks scheduled yesterday, and as we move forward, expanding access to that. In addition, we are finalizing the details around our mobile testing arm. So again, we're creating this huge buffet, and I know it's not wise to say buffets because they can be mechanisms of transmission with large folks coming in. But again, we're creating a huge source of trying to remove as many obstacles as we can to get folks testing opportunities. So thank you all for sending in those ideas and recommendations. We're continuing to look through those. And then we'll be announcing that larger effort hopefully very, very soon. We've spent a lot of time working in the background on those logistics. So stay tuned, fingers crossed. But I say all that to say that we have to improve how many people we're testing. We want to be aggressive in that, and moving towards a measure of about 5% would actually, I think that would break down to maybe 7,000 a day on average. So, we want to be bold and make sure we've got the things in place. Now, with that increased testing capacity is also the concept of test positivity. Currently, the state average is 19%, and in Montgomery County, the test positivity, and again, that's referring to when we test folks, what's the percentage that's coming back positive? We're somewhere in the low 20s. So we would definitely want to see that come down, and ideally have a maximum baseline of 15%. So have that test, as we test more people and get them identifying asymptomatic folks and get them isolated, We cut down on the networks of transmission and ultimately bring that number down. Contact tracing, I do want to highlight some components here. The measure we're looking at is having a sustained, robust system in place that would allow for initial interviews to be conducted within 24 hours and initiate contact tracing process within 48 hours of lab notification. Now, we're working in concert with our state team. The state, as some of you know, has hired NORC. They are hiring over 1,000 individuals to be able to go out and initiate contact investigations, at least the initial interview, within the first 24 hours. Now, that also includes an electronic platform that will allow us to customize the platform based upon our case reporting system. It also will allow us to more readily track measures, such as I know there's a request to include, the time within a case drops into the CRISP system and when they're called. And so we'll be able to, I don't have that data today, but we will be able to provide that. And so what we're also looking at is, I know there's been lots of folks talking about volunteers serving, helping with that effort. We do welcome volunteers, but we also recognize that this is going to be a sustained process. So we have utilized employees. For example, now we've trained over 50 school health nurses, but we know that they won't be able to work with us forever. Schools will start again. And so we will be looking to stand up an opportunity similar to what is done in DC and in Baltimore, where we will hire contract staff to be and train them to be able to provide that first layer to support the disease control team. And then any volunteers that would be brought into the system would be able to support those efforts moving forward. Because this is going to be a fairly extensive process. And so we want to make sure that we have the adequate investments in staff to be able to execute those needs. The last component is equity. So I think it's an important measure, and this is more of a qualitative measure, but any conversation about readiness to reopen must ensure that equity is being considered across all of these different components. So when we're looking at the types of businesses, I know Councilmember Rice has brought this up before, when we're looking at the types of businesses that are going to be reopened, when we're looking at, for example, when we know that there are disparities and inequities that have popped, well, we knew they existed before, but certainly as it relates to COVID-19, making sure that we have infrastructure in place. At a minimum, the conversations and initial infrastructure building has been put in place to address those inequities. And so that is, from an educational standpoint, making sure that we have great information out to teach people how to, physically distance, how to isolate, how to quarantine, provisions in place to address social support needs, as well as making sure that we have, for example, when we're talking about testing capacity, yes, we can expand testing capacity, but does it take into consideration access to those different services, whether we're talking about transportation needs, geographic diversity in terms of access, et cetera. So, and also want to update, and what's framing a lot of this conversation is, over the last week and a half, we've been doing some internal process improvement and review of what we're doing. And in fact, I had an extensive conversation with a former colleague who is an informal consultant who has used to work for CDC and has extensive background in epidemiology and surveillance. And part of that conversation was to review, in my mind as a public health person, that's an area where we need to beef up. And so consistent with that conversation and consistent with our efforts to, now that we're asking folks to follow these metrics, make sure that we're even more so data-driven and using the data to drive our interventions, we're going to create an advisory panel to help inform these measures that we have in place to ensure that we're continuing to move forward with them, as well as help us think through if there are any other measures that we need to consider, not only in the short term, but as we move forward through the different phases of reopening. In addition to that, another point I want to bring up is I had a great meeting with the Medical Society earlier this week, and we talked about how we've got to get people to understand, and this is more of a message to the folks at home. We need you, if you are sick, not COVID-related stuff. If it's COVID-related stuff, we still need you to access medical care. But if you have physical health needs, we need you to understand it's safe to go to the hospital and seek medical care. We had a conversation. There was a report from one of the cardiologists who's a member who said that he had seen a couple of cases where people had delayed coming to seek medical care, and by doing so, they were in worse shape. They were able to be fixed, but they were in worse condition, having delayed coming to seek services weeks later because of their concern. So we've got to do a better job of messaging and encouraging folks to continue to seek care, and that extends to a couple of other things. For example, vaccinations. We want to make sure that families still have provisions to be able to get their children vaccinated and immunized, because certainly in the fall, we don't want to have to potentially be dealing with the flu, COVID-19, as well as a potential outbreak of another infectious disease that could be prevented by vaccines. I'll stop there, but that's a lot of the stuff that we're working on, and wanted to share that with you all today.
Thank you very much, Dr. Gales. I want my colleagues to know there are 6 people on the list right now who want to ask questions. We only have about 45 minutes here to ask that, so please ask your questions, but remember that other colleagues want to speak as well. And with that, Councilmember Reamer.
Thank you so much. Appreciate the updates. Wanted to just start with testing. I just want quick questions on testing and on tracing. So thank you, Dr. Gales. We're at, on average right now, about 750 tests per week through the county facilities, if I understood you correctly. Yeah. We have, in addition, is that correct?
Yes, just for the county and just for the VEEP site and the 2 sites, yes.
Just for the VEEP site and the 2 sites. That's helpful, because that's what I wanted to focus on when I had asked about could we do 2,000 a day. It was really just through our own controlled administration. We have, so in addition to the VEEP sites, Montgomery County has 2 facilities. One is Germantown, one is Wheaton. They're both open 1 day a week. Why aren't they open 5 days a week? And why don't we have 5 sites or some other larger number?
So part of it is capacity in terms of the staffing. Again, there's a lot of logistics to go into executing the large scale sites. And because of that, I recognize we'd love to have more sites during those times. We've created these other opportunities and mechanisms for folks to be able to get testing. So this is why we're working on the mobile test site, because part of what we heard is that even within those sites, people still have issues in terms of getting access to it. So we've been looking at how we could leverage other resources to increase opportunities. For example, we could do pop-up testing at different clinical venues. So even if it's not a standing thing at those sites, we're increasing interfaces in other places. I agree wholeheartedly with you that we want to test more. That's why we're scaling things up. And one other effort that I did not include in terms of the 700 cases has been the testing that the ready responders have been doing that we've partnered with from the state. They've been going into homes directly to provide testing. They've been testing in our homeless shelters. Over the weekend, they actually tested one of the nursing homes. They went through and they've been assisting in that measure. So that actually adds probably close to 200 more tests to that number. And in addition to that, so I agree with you. We do need more sites. Part of this, we've been limited.
Understood. Is it funding? Is it hiring? Is it staff? Is it repurposing staff from other departments? I mean, I think the county council would say, whatever it is that is needed to stand up more testing capacity, we'll support you 100%. Is it funding? Is it whatever it is? And I think we've been saying that, all along. So what can we do to help stand up more testing sites, urgently now?
Well, I think so. First of all, I appreciate that and appreciate the continued support from that perspective. What we're trying to do is, we're going to announce a larger testing effort shortly. We've been looking at ways to simplify the process because, again, there are lots of logistical needs that go into executing the test sites. There's a fairly sizable staffing piece. We have repurposed, for example, a lot of our specimen collection teams are staffed by our dental staff who, with the dental clinic has been closed for the most part, have been repurposed to do that. And so we are, it's not a funding thing, it's a logistical thing. So part of what we're excited as we move forward in creating different options is to remove some of those logistical concerns. So for example, the mechanism that we're going to propose to do the high throughput testing involves self-collection, which requires less staff, requires less PPE, is more easily scalable to folks. And so I think that will help address the concerns and help augment the support that you all have for that. And again, part of it also is, again, we've been thinking through other strategies, again, to create a host of other options that aren't tied to, deep stations or a central location, including the mobile testing arm and including the hotline so that people can get referred to other places.
Thank you. I mean, it seems to me the executive branch ought to be supporting you with as much logistical support as is possible. There shouldn't be a logistics shouldn't be a barrier to scaling up testing, although they're a challenge. They are surmounted just by, execution at a high, with enough people at the table, I guess. So I would really, I think it's urgent that I'm excited about the high throughput testing technology that is, coming. But we could be at a higher capacity now while we wait. And I'm just unclear as to why the executive branch isn't putting that in place faster. On tracing, thank you for, your report. You've mentioned in the past Westat. I'm not sure if you're still, working on that, but I imagine you are. But I've also shared a couple of companies that are local that do medical services that have reached out offering to do contact tracing. When will we have under contract, companies to provide our own local operation? What will be the scale of that? And then secondly, I'm glad to hear you say that you would welcome volunteers. That is different than what I had heard in the past. Could we organize a volunteer corps, kind of like a Peace Corps, to come in? And I just know that there's so many people who want to help, even if it's only a temporary measure, and eventually we scale it back as it's professionalized. I don't know, but so could you please respond on those two elements of the tracing operation?
Sure. The last piece, so we do have kind of a volunteer corps, so to speak. It's through the Maryland Reserve Corps. And so what we've had folks do is when they've called in to say they want to volunteer, we've had them register with MRC so that we can, there's a vetting process there, and then they can, once they're approved, I don't think it's very intensive. It's just kind of confirming credentials. Then they become a part of the pool. So that mechanism is in place already. And so if folks do have an interest in volunteering, our volunteer coordinator is Jessica Pryor. Her email address is jessica.pryor@montgomerycountymd.gov, and they can email her and she can get them linked to the Reserve Corps so that folks can go through that process. And so as it relates to the larger in terms of contracts, so as I mentioned, the state has created this contract with NORC, as well as I'm blanking the name on the company who has the electronic platform, but they've contracted that and they're covering those costs. And so as we found out more information about that process, we, as part of our review process that I mentioned, we're looking at how we can repurpose our staff to be able to support those. And so we're going to be doing some, a little bit of reorganization with our team to look at how we can create teams that specialize in terms of, we already kind of have a nursing home outbreak team with our action team, as well as, specialized focused surveillance, both for the contact tracing component, as well as looking at the retrospective epidemiology component, so that we can start doing some of that initial contact tracing from the very beginning to see what may have been the roots of, infection and transmission within our community as the team continues to move forward proactively and prospectively with those new cases that come on a daily basis.
Thank you. If I could interrupt, we only have a half an hour left, or a little bit more than a half an hour, and we have 7 people on the list who want to speak. So what I'm going to do is remind everybody when you're at about 5 minutes, is so that everyone has an opportunity to ask their question. Next, thank you, Councilmember. Next is Vice President Hucker.
Thank you, Mr. President. Okay, we'll do speed round. Dr. Gales, thanks as always for everything you're doing. I'm glad you mentioned vaccinations. I'm glad to hear about the high throughput testing, especially focused on our first responders. Shouldn't we be at this point now doing temp checks and wellness checks with our firefighters at the beginning of their shifts?
So I have to check into that. I think part of, so let's well, I think not to belabor the point, so temperature checks are a good indicator, but at this point we are treating everybody, even with who are asymptomatic, as potential carriers of transmission. And so, for example, this was it was a step that the nursing homes had taken after the first wave, and we were still missing a lot of folks. And so I would say that that is fine, but also within the context of, with the deeper expectations of requirements of face coverings and then, PPE out in the field, that those are the mitigating pieces that have been put into place and requirements that probably offer more protection. Not to say that temperature checks aren't bad, but offer more protection within that. But I'd be happy to talk with you more.
I'd love to talk to you more about that. I don't want to belabor it. My understanding is, we have folks. Well, when I've asked, it's a best practice that we're not following. That we have. When I've asked why we don't, one of the responses I got was that we wouldn't have enough firefighters to respond to calls, which seems off. We don't want sick firefighters responding. And if a firefighter has a temperature, but we don't detect it, and they get in a crowded fire truck with other firefighters, we're really putting others at risk. So anyway, I can follow up with you. I'd love to talk about that more. Dr. Stoddard, thanks for the call with your help with the call with the 3 large mayors, mayors of large cities yesterday. I conveyed all that information, and they're looking forward to the call today with you. I know you've been providing PPE to nursing homes, you mentioned. What about our multifamily apartments? I'm concerned in particular. I'm hearing from Charterhouse, which in Silver Spring always has big problems, filled with African-American seniors, the population that's most being ravaged by this virus. And we have delivered some masks to them, but the management refuses to provide masks to the seniors that are asking for them. They feel like they're spending more on cleaning supplies, so they shouldn't have to supply masks. This is a company with $233 million in assets. Can we get them some masks or work together or pass a requirement that they need to do that?
Sure. So I believe, and I believe we did send out some cloth face coverings for them. In terms of other PPE, I think we'd be happy to consider it. Actually, we had a request from Leisure World a week and a half or 2 weeks ago that we did fill that for their staff too. So they should just follow the PPE request process that we're utilizing for providers and note the who they serve. And I don't see any issue with us helping to provide those.
Okay, terrific. I'll follow up with you on that and Ryderwood. Thank you, Mr. President.
Thank you. And you came in under budget, so that was very good. Next is Councilmember Friedson. Please, I'm going to hold everybody. I'm going to remind you when it's 5 minutes. Thanks.
Thank you. Thanks for the comments that have been made. Questions have been asked. Appreciate the report and the hard work. I want to ask, there's a lot of confusion. Obviously, I think all of us agree with the governor's decision yesterday. You noted it a little bit. A lot of information that has been given out, but limited details on what it actually means and what it's based off of, and how our county, Prince George's County, some other counties differ from that, where obviously our circumstances are different. And he even noted that in the comments. But could you explain the specific metrics and data that we're using to determine when we will open up, and what we can communicate to residents of what the decision will be based off of, where we are today and where we were going to be or where we need to be in order to reopen with respect to testing, contact tracing, positive tests, hospital surge, et cetera?
So that was the intent from the measures that I walked through. all of the different categories, those are the things that we're going to be looking at. And so just briefly, number of cases, outcome-related factors, including our hospitalization rate, our ICU utilization rate related to COVID.
Sorry, I don't want to interrupt. I appreciate it. I heard what you said. I think what is missing and what is hard for us to communicate with residents when they ask is what specifically is the target number or the target that we're looking at and where we currently are. And that would provide some level of accountability and clarity so that residents have an understanding of how far we are from opening and what we actually have to get towards. Right now, there's just, here are the types of things that we might be looking at without a metric associated with it of where we are. And I think that is what has caused the confusion with the governor's announcement. I'm not sure that we're providing much additional clarity, frankly, to be able to share with residents currently.
So we will. We didn't have the time to go into the extensive detail for those measures, but I'd be happy to provide you with them. So, for example, what we're creating is I'm not creating it, but the data team is working on creating a very clear mechanism to show exactly what you're saying, to say, even if it's just an arrow, up, down arrow to show how many days we've done it consecutively. And then, we can provide, and, there are some that are a little bit, for example, specific where I talked about, capacity to test 5% a week. So we can go through and say, here's where we are in that measure. When we look at the new cases in terms of decreases, we can put them side by side. So be happy to do that. Describing all of those would take some time now, but we'll be happy to send those measures.
I appreciate it. If you could send it to us, it'd be really helpful to be able to share with residents specifically what the metrics are and where they come from. We are getting bombarded right now, as you can understand, with questions, concerns, misunderstandings of what the governor's order means and where we fall into that. And as much specifics as we can provide and as much clarity as we can provide, it make everybody's life a lot easier, and we'd be forwarding you a lot less emails and phone calls. I promise. In terms of the testing per week, you mentioned the goal is 5% a week, 55,000 a week. Is that what you said earlier? I heard you properly.
Right. So the goal is to have capacity to do that. And that is it's not saying we as the county would do all of that testing, but, making sure that there is the testing framework and network to be able to absorb that number of tests.
So we're currently at about half of that to date for the entire crisis, and we at 2.8%, and we want to get to 5% every week moving forward. That's a big jump. So I'm very hopeful that some of the technology advances that you mentioned are moving forward, and very hopeful for that. I had asked previously about the question of inventory of what the capacity is in the private sector and the public sector. Do we have any progress on, if we're going to figure out what the capacity is, not just on the county side, which will never reach that capacity, as you mentioned, the 5% a week, but with the private sector, maybe we can scale up. Do we know what that scale currently is and how we get to where we need to go with the private sector in addition to the public sector?
I don't have that specific number right now, but we'll be happy to talk more in detail about that.
Great. And when you mentioned earlier about the 14 days, is that a rolling average of 14 days, or is that a declining number for 14 consecutive days?
So we're using the terminology rolling average because that gets to the point of there may be, for example, we've got 7 great days, there's one day that's not great, and then we've got 7 other days. So the rolling average allows for there to be an aberration. And, particularly if we can easily explain why, there may have been a higher rate on one particular day. And so that's why we're using rolling averages with consistent trends moving in the right direction.
I appreciate it. I'll just ask if we could get, finally, this is more for Earl, but a specific detail of who is working on the COVID response across all of county government, what that response team looks like, who's on your specific team, but who within the departments is working on this as well. I think that'd be helpful to the points that were made earlier about what the deployment of resources is for this response. If you could share that with us, I'd appreciate it. And thank you, Mr. President.
Thank you. Councilmember Rice.
Thank you very much. I'm going to try and be quick. So in Prince George's County, May 1st, 8,087 cases. May 12th, 10,459 cases. Montgomery County, May 1st, 4,754. May 12th, 7,130. I'm trying to understand how, if these, in two of the largest jurisdictions in the state of Maryland, if the cases have increased that much in just a period of 12 days, and the governor is using data saying that in the past 2 weeks, which is what he said, it was a 2-week average in terms of that, how in the world, if we have these thousands of increased cases in that 12-day period, could we say that we're even slowing down or keeping stagnant the rate of increase of infection in the state? Dr. Gales?
I would have to defer to the experts who provided that data input for the governor. What I can say is that looking at the numbers that you shared, I have an opposite response in terms of what the governor released. I don't, based upon those numbers, we're not ready to open up. And that is the consensus that has been shared with our jurisdictions in the National Capital Region, as well as in DC and Northern Virginia.
I appreciate that answer. And then my last one, Mr. President, you see I'm going very, very quickly here.
You're doing just fine.
When it comes to hospitalizations and when it comes to cases, and I completely agree with you that one of the things that's difficult is if you don't have all the numbers, it's hard to really look at trends. And so from that perspective, we have flat numbers for hospitalizations. We don't have hospitalizations per day. We also don't have cases per tested. And so that's the other thing that I think would be incredibly helpful. I understand that we're testing more people, but if, let's say, you test 1,200 and 500 come back positive versus you test 1,200 and 900 come back positive, that says something completely different. It's not just about the additional cases, it's about the percentage of the cases to the tested. And so we're not seeing that data. And I think that would be incredibly helpful, especially when it comes to justifying whether or not we reopen or not certain areas in terms of folks understanding. I will just highlight, and I can't remember where I saw it, but in a study to where they actually tested 1,200 people, over 50% of them came back positive. That is staggering and concerning to me. It may not be to you, you're on the front lines, you're seeing that, but if half in this study, and they were primarily Latino, I do remember that part of it as well, as a part of the study. So again, I'm very concerned about having that data and access to all of it. Do you have access to all of it, first of all? And then secondly, is there a way in which we can also look at that as folks that are out there explaining this to our community?
Sure. So two quick things. The first point what you're speaking of is the test positivity. So, when we're looking at that number, that we do have access to that data. And so the state data has been steady at 19% probably for the last week or so. Our test positivity in Montgomery has been a little bit higher because we've had more cases than on average across the state. And so ours is about 22 to 23%. Again, the state's is around 19%. It's been steady. Now, certainly that is a good indicator because if we see it go up, it's not just a question of we're testing more people. It's are we missing an outbreak or something like that that's in a controlled setting, which underscores why the more aggressively we can test people, we can identify them, particularly the asymptomatic folks. We estimate anywhere 20 to 25% of those who are COVID positive are asymptomatic and unknowingly transmitting it. So if we can identify them quicker, we can isolate them faster, interrupt those networks of transmission. And so to the second point, I'm sorry, could you repeat the second question?
Yeah, so the second one deals with hospitalizations and just understanding that and whether or not we have the data for that as well.
So we do have data, and what we can do is the team is actually working on a one-pager or a very succinct memo that has some of these to take the criteria that we mentioned and lay it out so that we can provide for you all and for the county exec on a daily basis. So you have some insights in terms of where the numbers are going as well.
Last but not least, just very quick comment. If in fact we're consistent in terms of numbers of infection, but yet we have more PPE, we have social distancing practices in place that we didn't have before, that also says something to the level of contagion and what's going on, and that there's also some sort of increase because you have to balance how much you're doing to protect from having an increase as you have the increase. That's it.
Thank you very much, Councilmember Alvarez. Let me just say, Councilmember Navarro is the last speaker. So anybody that speaks over, you're taking time away from Councilmember Navarro. Not that I want to put any pressure on anybody. Councilmember Alvarez, please.
So I got a text message from my pastor in the last 15 minutes asking, does this mean we can go to church on Sunday? You know, based on the, and of course the answer is no, but that just speaks to that this press conference this afternoon is critically important to be very clear on the delineation to everyone's point, and the chart that you're working on that gives those numbers. In addition to sharing that with us, I think it should be posted on the COVID-19 website for the county and then updated regularly so that we can point people in that direction, which I think would be helpful. Just three quick questions. The first is, were the cases of children getting COVID and that unique strain in New York, any updates on that, Dr. Gales, in terms of what we're hearing? I'm getting questions from parents, I'm sure others are as well, with concerns specifically regarding that strain or how that is related to what we're seeing now.
Sure. So there has been reports, and so from a pediatric standpoint, the pediatric pathophysiology behind this is pretty fascinating. There's reports, I know that there are cases in DC at Children's National Hospital, and there's some cases in Chicago. Again, that's where I'm most familiar with. And it's producing what's called, there's a disease syndrome called Kawasaki's disease, which is an inflammatory vasculitis type process. And the COVID strain that you're referring to, or the strain, is that we're seeing that pop up in pediatric populations. Not sure what the pathophys behind it is yet. We have done a preliminary look to see if any of our pediatric cases have demonstrated those symptoms within the county. As best as we can tell, we haven't seen any. I've been in contact with some folks at Children's though to find out more information about what they're seeing across the region. Although, because certainly, you know, we want to be aware and have that on our radar.
Thank you. And then switching gears quickly, what's your goal for contact tracers? What's the number you'd like to get to for how many people would be on your team?
Sure. So the estimate that we're looking at is most models either look at if you're looking at one contact tracer per 15 cases or one per 30 cases. And so that's what we're trying to estimate. And so that puts us somewhere between 150 to 300 contact tracers based upon that. One thing that will help significantly is the state system. The way they've structured is the state is coordinating, or will be coordinating, handling those initial interviews. And so when the data drops into the CRISP system, those folks will perform that first contact investigation within a 24-hour period, which would help free up some of the local staff to then be able to do some more of the intensive follow-up with the contacts that have been identified. And so we estimate probably somewhere within the 100 to 200 range in terms of additional staff to support.
And of course, you know this, but it's important for those contact tracers in some cases to be multilingual, to
Yes.
be able to track back and be culturally sensitive and understand those communities. I'd suggest we did a great job in training our census staff who are not being utilized as much as we envisioned them because of everything that's going on right now. And there was a great intention on making sure that that team of people reflected the diversity of Montgomery County. Maybe a good source to tap into some folks who have been trained on how to reach our communities and know where to go. So I'll defer my questions for some other time because I want others to ask as well. But thank you very much, Dr. Gales, and thank you, Dr. Stoddard.
Thank you very much. Councilmember Jawando.
Thank you, Mr. President. And I just want to go on record. I'm a big fan of the 5-minute time check. Reminds me of my Capitol Hill days. So let's implement it more often.
Fine with me. Go ahead.
Yeah. So Dr. Gales and Dr. Stoddard, good to see you. Thank you all for your work. 3 questions on testing. Who's getting tested? Have we gotten to the point where I've asked before of the demographic breakdown on who's getting tested, not only the numbers but the equity point of who's getting tested, what regions, age, race, ethnicity? Are we reporting that? And on the actual who's getting testing, not on who's positive, but who's actually getting access to the test?
Sure. So we're not reporting on that. We're working on that. I think we have, again, tied to the lab results, gender, age, and zip code of where they're coming from. We do have, and we've been working to try to get more data. So we do have racial data on a percentage of it. And literally earlier this week, we talked about saying it's probably maybe it's up to maybe 30% of the cases now, is that now that, unfortunately we have a larger number of folks, is that we would be able to come in and just release what we have and say, this is incomplete, but based upon what we have,
representative sample. Yeah, that would be helpful. And I don't know, maybe, and seeing the zip code data again of who's getting tested, not just, I know we see the zip code data of where the infections are. I think if you could start adding that to the updates, that would be helpful. And sure. I think something we should be tracking. Thank you. The other thing, I was really excited to hear that the hotline is up and running. Did I hear that correctly?
Yes, and I was told not to call it a hotline. It is the testing helpline.
The testing helpline. Yeah, we don't want yeah, sure. Okay, testing helpline. What is that number for the millions watching at home, as I like to say? Can you give that number out right now?
Sure. So the way people access it is they call our disease control number 240-777-1755. And when they call that number, they'll be asked, they'll say, I'm calling to get screened or triaged. They will be given an appointment time. And at this time, we created the opportunity for providers to be able to work remotely to increase the number of folks that we have. And so they'll get an appointment time. The provider will be contacted and then call the individual back directly to talk through that situation.
240-777-1755. And can you dial 311 and be directed to that as well? If not, we should work on that. We should make that connection. I'm sure we could do that, but let's work on that.
Yep.
Great. And then the last question, nursing homes, we have obviously had a lot of talk about this. I know you guys were getting into inspecting. How many more have you inspected, and how is the testing going throughout the nursing homes?
So the governor's special operations unit, or special forces unit, has started their testing. They've been to a number of facilities already. We were asked input in terms of how they're prioritizing going. They're looking at capacity, the number of cases, those kinds of things, and so that process is fluid and ongoing. And again, what we're hoping to do is, we've leveraged the rapid responder team to start helping in that process. So they've gone into some facilities and are checking off the list as well. And the hope again is that once we are able to announce the high throughput test, our goal is to be able to go in and provide testing to those facilities as well, because we want the state system is over time, and we want to try to get as much done as we can in a short period of time.
So how many more have we inspected? Because I'm running out of time. I can feel it. How many more have we inspected since last week?
Since last week, we went into the facility that I mentioned, and there's another facility that we've been working with, but we haven't done any local inspections. The state action team has come in and visited, I think, 3 or 4 facilities since we last met.
All right, thank you. And then we just obviously need to keep making that progress. Thank you for all your work.
Thank you, Councilmember Glass.
Thank you, Mr. President. And I just want to be on the record in supporting this 5-minute time check. Thank you very much. I have one question. I have one question for you, Dr. Gales. I know that you're going to elaborate on many of the questions that we've all asked in a few minutes. You are clearly dressed for a press conference. So my question is, given our geography, steps away from Eastern Avenue, Western Avenue, the Potomac River, while we have these metrics that you are putting in place for opening up Montgomery County, clearly the region as a whole, the Beltway area, there needs to be some coordination, and individual jurisdictions can't act independently. So can you share with us what types of conversations and methodology is being developed with regards to the region?
Sure, that's an excellent question. I'll be very succinct. So we've been working with our regional partners, both at the state as well as National Capital Region from the very beginning. Over the last 2.5 weeks, as we have noted that we've kind of read the tea leaves that there would be these efforts to reopen. We've had separate conversations, so that all of the National Capital Region folks have been meeting. I know the CAOs, the elected officials have met, the health officers have met. We've shared our metrics of each of our different jurisdictions to make sure that they're very similar. So they may not be identical, but they're very consistent across the board. Similarly, even as recent as last night, the health officers from a number of different jurisdictions in Maryland had the same conversation where we shared our metrics. And so we are all very consistent in terms of what we're looking at to be able to determine if we're ready.
Excellent. Thank you very much for that. And in a nod to Councilmember Jawando's point, I yield back the remainder of my time.
Thank you very much. Councilmember Navarro, I should have mentioned you much earlier. They gave you a lot of time, almost 6 minutes.
That's amazing.
Councilmember Navarro.
Thank you so much. First, thank you to Dr. Stoddard and Dr. Gales. It's great because a lot of my questions were answered, including wanting to ask for the number for the testing helpline. So I'm glad that we were able to get that out as well. No doubt that right now we're definitely, dealing with two main issues, making sure that we provide some clarity to our residents regarding this opening situation. And I hope we'll be watching the press conference, but I hope that we're able to communicate very clearly, even if it's some, rough timeline. I know DC has done that from the get-go. I think people really like that because at least you kind of organize and understand maybe what our target might be. So I hope that we get to that point. But also wanted to make sure that we continue to figure out how are we going to strategically focus on those zip codes that we keep talking about over and over again, right? To 0902, 904, 906. And now even more than ever, because one of my concerns, of course, is that with all this talk about, soft opening, not opening, et cetera, that confusion, I think will disproportionately, again, continue to affect those zip codes. So, I don't have a lot of questions because many have been answered, but just to reemphasize that I would like to see us figure out how to strategically serve those zip codes, whether it's the testing issue, Councilmember Reamer brought up, we've talked about that before, that we need to be, much more aggressive and figure out what the barriers are. And I'm glad that, for example, there's a site in Wheaton, but obviously we need to have more in these zip codes, which is Silver Spring, the White Oak area, the Briggs Cheney area, Wheaton, Aspen Hill, Glenmont. All of those areas are really important. And lastly, just to say that in terms of communications, again, more than ever, gotta make sure that we're on target with the messaging. So we've had the briefings also on Monday, so I don't have a lot of specifics, but let's continue to work together as we have and figure out again how to be very strategic. Because if we don't address, especially those zip codes, then the broader strategy then gets affected, right? Because we're not able to realize the gains that we're looking for. So again, thanks, and I'll be waiting to see what it is going to be announced very soon. Thank you.
Thank you very much. We did come in, we did manage, we got there. I did want to, though I didn't ask my questions till the end here, I did want to mention to Dr. Stoddard that I too, along with Vice President Hucker, was on the call with the municipalities of the three larger municipalities, the three mayors. And we did appreciate your information, and I do believe that it's very necessary, and I know that you're meeting with them. I didn't realize it till yesterday. But I know that you're meeting with them on Thursdays, and that's a great help. But I do think we need to make certain that our communication continues even more than just that with them. They're obviously doing some of the work that that the county would normally have to do.